Hi, I'm Dr. Linda Shiber, and I'm a minimally invasive gynecologic surgeon at Metrohealth Medical Center in Cleveland, Ohio. I will be speaking about managing gynecologic trauma with minimally invasive surgical techniques. Thank you to SAGES for the invitation. I have no disclosures. The objectives of my talk are to identify candidates for an MIS approach and apply MIS techniques to trauma scenarios and gynecologic and obstetric scenarios. So in trauma, the candidates for a laparoscopic approach would be stable patients with a suspected intrapelvic or intra-abdominal injury. This can include individuals who have suffered trauma and have equivocal or nonspecific imaging findings such as free fluid, or patients who have had a penetrating abdominopelvic injury. Laparoscopy can be used to evaluate the integrity of the peritoneal cavity. Contraindications to a minimally invasive approach for trauma patients include a high likelihood of bowel injury, frank peritonitis, hemorrhagic shock, or hemodynamic instability. The advantages of using laparoscopy for trauma include there is a high sensitivity on a laparoscopy for detection of a problem. The risks postoperatively of laparoscopy are much lower than those of a laparotomy. Laparoscopy is associated with decreased pain, decreased incidence of ileus, decreased hospital length of stay, and fewer wound complications. The incidence of a negative laparotomy in trauma has been described up to 30% of the time, and this, of course, is associated with high medical costs and perioperative morbidity for patients. Also, laparoscopy can allow treatment of the injury, whether it's repair of a bleeding solid organ or resection of a perforated organ. We can do a lot more with a laparoscopic approach nowadays than just a few decades ago. Further, the scope offers excellent visualization around anatomic structures and is safer in pregnant patients. The risks, however, of performing a laparoscopy for a trauma patient include a potential delay to definitive treatment. So if you notice a large bowel injury that requires resection or repair on laparoscopy, much of the time this will delay proceeding to laparotomy somewhat. There's also a small potential for missed injury. These rates are described as very low, under 1%, when laparoscopy is used as a diagnostic modality. And then potential for false positives on laparoscopy, resulting in a potential increase in a non-therapeutic laparotomy risk. So in gynecology, traumatic pelvic injury is an uncommon surgical indication. However, we utilize laparoscopic approach for virtually all non-traumatic gynecologic emergencies. Trauma scenarios for which laparoscopy could be applied include straddle trauma with suspicion for intrapelvic injury, sexual trauma if there's suspicion for intrapelvic injury, post-hysterectomy traumatic cuff dehiscence, penetrating or blunt trauma to the uterus, adnexa, bladder. Again, there's rare data to guide practice here. These injuries are often associated with massive hemorrhage. And then, of course, we have the much more common non-traumatic gynecologic emergencies for which we always do laparoscopy, which can be hemorrhage due to a ruptured ectopic pregnancy, tubo-ovarian abscess, ruptured hemorrhagic cysts, uncontrolled uterine bleeding. So a few tips when approaching gynecologic trauma with a laparoscopy. So first of all, positioning is very, very important. We position our patients in dorsal lithotomy position, and this enables us to have vaginal access to the pelvic organs as well as laparoscopic access. A uterine manipulator can be very, very helpful if there's suspected pelvic trauma. Uterine manipulators are placed vaginally into the uterine cavity. There's a small balloon on the tip of the manipulator that holds it within the cavity, and then the green and blue cups that you can see here on the screen hug up to delineate the cervical vaginal junction. We also often attach the Foley catheter tubing to cystoscopy tubing and then attach that to a half-full bag of saline. This enables us to assess the bladder through backfilling during the surgical procedure. Entry can vary depending on previous surgical history, the habitus of the patient, and the location of a traumatic injury. Generally, the preferences are going to be open technique at the umbilicus versus left upper quadrant entry at Palmer's point. I always use a 30-degree laparoscope in my cases to enable improved visualization. Before we do much, we always perform an upper abdominal survey with the scope before placing the patient in Trendelenburg to clearly visualize the pelvis. Again, the uterine manipulator can be very helpful here to view the posterior cul-de-sac and the ovarian fossa and pelvic sidewalls. If necessary, backfilling the bladder with the Foley apparatus I described can be helpful. Also performing leak tests to evaluate the rectosigmoid colon for injury is also very, very commonly utilized in gynecology. Placing ancillary 5mm trocars can allow additional hands to help retract and move structures to enable careful evaluation of the pelvis. And then adequate suction is important as well in cases where there is active bleeding. So after assessing the situation for in a gynecologic trauma patient, the next step is to assess and control any bleeding in the pelvis. The vascular supply to the pelvis originates primarily from the anterior division of the internal iliac artery, whereas the ovarian blood supply is via the gonadal vessels, which branch directly off the aorta. We know in gynecology that massive blood loss can occur from tiny structures, such as with a ruptured ectopic pregnancy. So depending on where the bleeding is coming from, excision of a structure versus usage of bipolar energy versus suture repair are all modalities that can be employed. If extensive dissection is required, advanced bipolar devices can also be used, or advanced ultrasonic devices as well. In cases of diffuse hemorrhage, hypogastric artery ligation and uterine artery ligation are useful at the origin of the uterine artery, are useful techniques as well for managing pelvic hemorrhage. This can be performed by opening the pelvic sidewall peritoneum at the pelvic brim, medial to the infundibulopelvic ligament. We then dissect the ureter medially. As you know, the anterior division of the internal iliac artery is parallel to the course of the ureter, and ligation is generally performed before the branching of the uterine artery. And it's important to take care to separate the artery from the vein, so ligation of the artery only is performed. This can be done with vascular clips, and these clips could potentially even be removed at the end of the procedure once bleeding has been fully resolved. IR embolization is another thing to kind of keep in the back of your mind if there's diffuse bleeding and this is not possible. Embolization can be very, very helpful in minimizing blood loss. And then if bleeding is coming primarily from the uterus, hysterectomy can be a final option to control things. We also use suturing techniques extensively in gynecologic laparoscopy. Suturing can be used for hemostasis at the bed of a ruptured ovarian cyst. As I will speak about in a moment, uterine injuries are very amenable to suture repair. And of course, things like post-hysterectomy cuff dehiscence are fixed generally with PDS sutures. This can be done laparoscopically or vaginally. So organ by organ, the uterus, in the event of a traumatic injury that causes a uterine injury specifically, these are generally injuries that can be repaired and the uterus can be preserved. The uterus is comprised of a thick myometrial wall, and then of course the endometrial cavity is deep to the myometrium. It's important with a myometrial uterine injury that the injury is closed in layers. And this is of key importance in patients of reproductive age to minimize the risk of uterine rupture should a woman become pregnant after repair of such an injury. My preference is generally to use barbed suture, since often we're performing 2 or 3 layer closures of hysterotomies. This increases efficiency. I also like to inject intramyometrial dilute vasopressin, which can minimize bleeding at the site of an injury as we perform the repair, and also improves visualization. As I mentioned above, unilateral ligation of a uterine artery is also a reasonable technique and can be done in a temporary fashion with the clips removed at the end of the case after the organ is repaired. But generally, the uterus heals very well. It is important if there is a breach of the endometrial cavity that IV antibiotics are given to the patient, since we consider that clean contaminated. The fallopian tubes, in contrast to the uterus, are much less forgiving. If there's significant tubal trauma, my recommendation would be salpingectomy, which is an easy and efficient procedure rather than attempting repair of a fallopian tube. And this is really just because of the high risk of subsequent tubal scarring and tubal dysfunction, which can then result in ectopic pregnancy. The images on this slide are actually of a ruptured tubal ectopic pregnancy with hemoperitoneum, sort of the before and the after the tubes were resected and bleeding was controlled. In terms of the ovaries, again, ovarian blood supply descends in the infundibulopelvic ligament and originates from the aorta. If there's a minor injury to the stroma of the ovary, bipolar energy can actually be used to control ovarian bleeding. The other option is to repair the ovary. If there's bleeding in the bed of an ovary after excision of a large cyst, we usually control it with bipolar and then interrupted or figure of 8 sutures using a monofilament suture. However, if the infundibulopelvic ligament is compromised, this is the sole blood supply to the ovary. So generally in those scenarios, an adnexectomy would be indicated. And I wanted to end with just a few notes on laparoscopy and pregnancy. So laparoscopy is preferred over laparotomy for surgical approach in pregnancy. Again, just like in gynecology, the most common indications for laparoscopy in pregnancy are non-traumatic indications. And laparoscopy, of course, conveys all the benefits listed above. In pregnancy specifically, this is a hypercoagulable state, and performing a laparoscopy rather than an exploratory laparotomy confers lower additional risk of venous thromboembolism to these higher risk patients. Also, visualization around the gravid uterus is much improved when you have the ability to utilize a 30-degree scope. The more common indications in pregnancy for any type of laparoscopic surgery would be acute appendicitis, cholelithiasis, cholecystitis, ovarian torsion, and large symptomatic adnexal masses. The safest imaging modalities for pregnant patients are ultrasound and MRI without the usage of IV gadolinium. So important, we generally try to avoid CT scans in these patients. The traditional teaching about when to do surgery in pregnancy was that laparoscopy or any surgery was safest in the 2nd trimester. However, more current evidence suggests any trimester is okay if there is an appropriate indication for surgery. It's important for these patients to be placed on a bit of a tilt, so we prefer a left lateral decupitous position. This minimizes inferior vena cava compression from the gravid uterus, with resultant decreased venous return to the heart, decreased cardiac output, hypotension, and decreased placental perfusion. This is most important when the uterus is larger in the 2nd and 3rd trimester. In the 1st trimester, doesn't really matter. You can place the patient flat as usual. There's really no evidence for adverse effect of CO2 pneumoperitoneum on the fetus. Ideally, however, we prefer to keep intra-abdominal pressure no higher than 15 millimeters of mercury. Higher pressures can result in further elevation of the diaphragm in pregnancy with a resultant decrease in functional residual capacity and lung volume. And then we do recommend non-invasive maternal CO2 monitoring, generally keeping the end tidal CO2 less than 32 is ideal. I mentioned on the last slide, a 30-degree scope is important. Using atraumatic retractors can be helpful. We generally avoid manipulation of the gravid uterus, but when necessary, a fan or a liver retractor can be very, very helpful in seeing around the uterus. And then all patients should receive sequential compression devices. For higher risk patients with a history of previous VTE, heparin can be safe in pregnancy. And if the pregnancy is viable, it's important to document heart tones, fetal heart tones pre and post-operatively. And that's all I have. Thank you so much for your time, and here are my references.